right, hello and welcome back. I'm Eric Sunset, your host of the Doc Buddy Journal. Here at Doc Buddy, of course, we deliver healthcare solutions that take the pain and cost out of broken workflows, like with our OpNote solution, which gives ASCs and their affiliated clinics the power of instantly generated operative reports. You can learn more about that at docbuddy.com. And I'm really excited to reintroduce Dr. Dan Blumenthal to you, our listeners. He is the Chief Quality Officer of CVA USA, and that is the Cardiovascular Associates of America. And with all that, Dr. Blumenthal, thanks again for joining us.
Oh, thank you, Eric. It's a pleasure to be back.
We're psyched to have you. And in the time since, there's been a lot happening for CVA USA. There's been a lot happening for you now as the Chief Quality Officer. What's new since we last spoke?
Yeah, well, we continue to grow and continue to advance our value-based care mission. We've I think when we spoke, we had entered into a few risk contracts. We've since continued to expand the number of value-based care contracts that we've signed and are doing value-based care in multiple states now. From a quality standpoint, we've advanced a lot of our work around quality measurement, both looking at transitions of care and rehospitalizations, and measuring patient satisfaction systematically, measuring quality and MIPS performance. That's been a big area of focus for us this year from a quality standpoint, and continue our work to build out evidence-based protocols for managing cardiovascular conditions and care efficiently and in an evidence-based fashion.
Love it. And love to hear that folks like you and CVA USA are sort of turning the paradigm on its head. The paradigm being, strict fee for service. There isn't a physician in the country that doesn't care about their patients and want better outcomes. But this is a systemic approach to healthcare in the U.S. So really glad to have you back on to talk about that.
Well, thank you. Yeah.
Going back to our show in January, one of our hotter topics was discussing the cardiovascular procedures that were coming off of the IPO and being allowed to be performed and completed in the ASC. So we've got now 8 or so months to better part of 2024. It's a little bit less in the headlines, though that doesn't mean that momentum isn't still building and gathering and excitement still isn't there. So one of the things I wanted to hear from you are, over the course of 2024, what are some of the best practices that you've seen for bringing these cardiovascular procedures to the ASC?
Yeah, so it's a great question. I think fundamentally there are a variety of procedures that are already approved, right, to be performed in ambulatory surgery centers or office-based cath labs. Mm-hmm. And so once the procedure is approved, can be done in an ASC or an OBL, then it's really up to the physician and the patient about whether that patient has certain clinical criterion, right, that would warrant doing the procedure, or procedural criterion that would warrant doing the procedure in outside of an ASC, or whether they're appropriate for an ASC or office-based lab. And we've started to put together some suggestions, guidelines, right, around guidance around how to make those decisions. But we trust our physicians, our clinical partners, to know what's best for their patients. The criterion, this year Medicare had several procedures that were on that list that were up for comment to be moved from the HOPD setting, or to be eligible to be performed in ASCs. And by and large, most of those after comment were removed from the suggestion list, and so didn't make it into the final rule. And most notably, ablations, right? AF ablations and SVT, or supraventricular tachycardia ablations. We are seeing payers start to, non-Medicare payers or Medicare Advantage payers, start to contract for those anyways in ASCs in select circumstances. And we know that payers have been doing that for years in certain parts of this country. Um, we also saw HRS, the Heart Rhythm Society, and the American College of Cardiology come out with a joint letter endorsing the safety of AF ablations in ambulatory surgery centers for appropriately selected patients. And so while those are not yet approved by Medicare to be done in ASCs, we do anticipate that it's only a matter of time before some of those procedures migrate to ASCs for traditional Medicare patients. Medicare approves them. The the Heart Rhythm Society also did its own survey of electrophysiology, kind of surveyed some of its members about what services and procedures they thought were appropriate for ambulatory surgery centers, and asked them about the percentage of procedures of those procedures they're doing in the hospital outpatient setting as a same day procedure. And those data they were published by HRS, the Journal of the Heart Rhythm Society. But the full results of that survey, I think, are also available through the HRS website, even including some of the data that they didn't publish. So that's just an interesting tidbit. And I think this has been an area of intense and growing interest among cardiologists generally, and EP physicians in particular.
Well, it's interesting you mentioned that, and we'll of course track down a link to the Heart Rhythm Society data and get that into the show notes, like we always do. As a vendor, we see a lot of ambulatory surgery center society events across the country, whether they're state shows or a
Yep.
Becker's event, or with ASCA, the national pack for ASCs. And we end up talking to a lot of the specialties that you would expect. A lot of eyeballs, a lot of retina, a lot of ophthalmology, a lot of GI, your traditional, more traditional specialties in the ASC.
Yep.
When we ask about cardiovascular procedures, the multi-specialty clinics often say we would like to do that, but we're not totally sure what we should be doing. And there's a variety of stakeholders there, from surgeon to the patient to the actual facility.
Yep.
I heard it put to me this way recently, that more of the same type of procedure is just more. You can scale that. You can kind of know what you're doing and just expect more staffing and more throughput and more supply usage and things of that nature.
Yes, that's right.
Cardiovascular is different, though. That's not more of a procedure that you're already doing. So, do you have any words of wisdom for those that are, seeking to bring cardiovascular cases, whether that's on the
and you mean, yep, and again, I think you have to start with, you always start with, is the procedure appropriate, necessary, appropriate for the patient, right?
Sure.
And I think that I think there are a few reasons why cardiology is difficult for multi-specialty clinics to kind of wrap their brains and their arms around. The first, I think, is that it requires expertise, which is pretty varied, right? There are a bunch of different procedures. It's not just cataracts or colonoscopies. These are a wide variety of not just kind of coronary procedures or electrophysiologic device procedures, implants, but also peripheral procedures that involve pretty complex and extensive peripheral vascular work, at least in office-based labs, and so, if you're not trained in that specialty, it's hard to perhaps wrap your arms around and your head around how the risks and the benefits vary across those different procedure types, based upon the characteristics of the patient. And because there's so much nuance around making kind of decisions based on who the patient is and what that patient's particular clinical comorbidities are and the reason for the procedure, you do need to really have expert guidance from somebody who's trained in those procedures. I think, I'd want that if I were talking to an ophthalmologist about whether or not a cataract surgery should be done in an ASC or OBL. But I would imagine that almost all of those can be done in an ASC in the same way that almost all colonoscopies can probably be done in an ASC. So that's the first reason. I think the second reason is obviously it's your heart, right? It's and so there's a level of risk aversion, I think, again, amongst people who aren't trained in cardiology, and about whether or not it's safe to do these procedures in ASCs, which it, for the vast majority of patients, for those that are approved, it is. Um, and I would say almost all, right? The physicians who I've met who work in ASCs tend to make very wise and conservative choices about who to do a procedure on in an ASC versus doing it in the HOPD setting or even in the inpatient setting if there are extenuating circumstances. It's really when it's your patient, right, and your judgment, you really have you really feel a responsibility to the patient, to your oath, et cetera, to do the right thing. So I think that those are two important reasons. The third is that there are lots of state level nuances, right, around regulations in terms of not just CON, but what procedures can be done in ASCs. If you can do cardiology procedures in an ASC, there's some states where you can do EP procedures, but you can't do coronary procedures. There's some states where you can do coronary procedures and EP procedures. There's some states where you can do it all, but there are CON laws, and so that limits your ability to actually get approval to build an ambulatory surgery center in a place that's convenient to you and your patient. So a lot of nuance here, and I think that also can make it challenging for people to understand. And then the final piece is that we generally need our own equipment, right? Outfitting an EP suite in a cardiac or an interventional suite requires a C-arm and some different materials, not just different catheters, but different training for your staff and techs, and so that can present some challenges in terms of understanding, right? If you're not a cardiologist.
Too true. All that's too true. More is more. Different is very different. And
That's right.
It's satisfying to see progress be made. We want to go, just generally speaking, as fast as we can, but still maintaining the safety, number one, quality outcomes, number two. So with all of that said, do you think more could be done in less time, or are we kind of on schedule from your point of view?
I certainly think I think that there's probably more that can be done. I think whether we're on, I would like to see, for example, ablations be approved to be done in ASCs, particularly, right-sided ablations make all the sense in the world. I mean, we're doing, 90% of those as outpatient procedures on hospital campuses in the HOPD setting. AF ablations, I think, can be done safely for a substantial minority, or if not a majority, of patients with atrial fibrillation who need a PVI. And I think we will. I think that we will continue to see. I mean, my prediction is we'll continue to see slow, steady progress, right? And I think that we'll probably see those procedures approved in ASCs in the next 2 years. Would be certainly my hope.
Sure. Yeah, and I'm right there with you. We fly the flag for our friends at ASCA and for the ASC in general. This is a great venue of care, and when it makes sense, it makes the most sense, at least in my humble little opinion. So then looking out to either 2025 or to that second year that you mentioned, 2026, or over the next 2 years, rather, is there anything in particular that you think either cardiologists or the ASCs that are interested in cardiovascular procedures or de novo facilities looking to be built for cardiovascular procedures? Is there anything you're keyed in on in particular in sort of this near-ish term?
Yeah, there's a little bit. There's one thing I think. There's a little bit of I'm actually transesophageal echocardiograms, right, which are basically echoes with endoscopies. Are I think have been an area of controversy because they really should be allowed to be done in ASCs, and there's been some resistance to adding them. EP, I think we did see. I'll be curious to see whether the addition of the PA monitors, which were added to the ASC eligible list this year, whether we see movement of that procedure in a substantial way to ASCs. It's a pretty it's a relatively speaking, no procedure is benign. I don't want to misuse the term benign, but it's for a cardiovascular procedure, it's a on the lower end of the risk spectrum, and we've seen growing use of those procedures. I think things like Watchman's, when again in appropriately selected patients, I think that the crossing of I mean, I'm not entirely, I would think that those, if you're going to look at approving ablations, then approving Watchman's would make sense. So those are left atrial appendage closure devices.
So it sounds like there's still a lot of reason to be excited about the momentum that it's going to carry
Absolutely,
forward.
100%. Yep, 100%. And I'm just, and I think down the line, is there a world in which we're doing TAVRs in ASCs, or MitraClips? I think we're not quite there yet. I do think there, for low risk patients, I think there's probably at some point a world where in the next 5+ years where we start to move some of those into ASCs, with the right safeguards and the right patient selection. But we're not there yet.
And to that point, not there yet. Is that a legislative or a regulatory hurdle to be cleared? Is there a technological hurdle that needs to be cleared before those make the most sense to be done in the ASC? Like, what would be the slowdown there?
Yeah, I mean, those. Well, typically you need to be doing the procedure needs to be able to be done in a substantial number of patients as a same day procedure. Right, that like the progression is typical, at least in my observation, has been, when for reasonable, appropriate reasons, clinicians, when we are learning how to do something, when it's higher risk, right, when there's any uncertainty, we want to monitor patients after the procedure to make sure that they are safe and that we can identify complications, and that they get any necessary post-procedural care that they need. And then as we kind of improve operational performance and efficiency and get better at doing the procedure and delivering all the necessary post-procedural care and identifying complications quickly, and as the technology improves, generally, those lengths of stay shorten, and then in some cases you can do the procedure same day, right? And but we, for obvious and appropriate reasons, I think we're incrementalists. We don't like to make big leaps in terms of changes in practice without kind of being methodical and making sure that those steps make sense. And so we just have to go through the progression, I think, for those other procedures, and learn which patients are appropriate, again, for shorter lengths of stay, for perhaps same day discharge, and then after that, which of those patients could be appropriate for being moved off of a hospital or health system campus.
Sure. Yeah, that patient selection aspect is obviously huge for all ASC based procedures. And that kind of turns our conversation a little bit towards patient adherence, because in
Yeah.
order to be a good candidate for a procedure in the ASC, whether it's cardiovascular or otherwise, there are some things that need to be considered, like
Yep.
you already mentioned, and I'll get way out of my depth here really quickly, but comorbidities, are you healthy enough? Are you going to be able to go home in one day? Should you go home in one day, even if that's likely? And flashing back to our prior conversation from January, I was fascinated around everything that you shared, and would really truly recommend, if you didn't hear that show, go back and listen to it. But we went really deep
Thank you.
that there are patients that, despite the physician and their care team's best efforts, are just not doing the right things for themselves. Whether that's
Mhm.
for an inpatient procedure where they're staying a night or two, or whether it's done at the ASC. And this is kind of a long walk for a short drink of water, Dr. Blumenthal. But what have you seen over the course of this year, and really over the course of your career, and best practices that, as a physician, you want the best for your patients? We know that
Yes.
that's absolutely true. But Mr. Patient, Mrs. Patient, you have got to either do this or stop doing this.
Yeah. So it's a great question, and it's a really hard question to answer. I mean, obviously, if we had easy, scalable answers to it, we would be in a different place. But I think there are a few themes, right, that kind of continually come up. One is you need to understand the motives of the patient and their belief system, and often when a patient doesn't take your recommendation, it's not because it's very rarely because they don't believe you, or that they don't trust you, or they don't think that, or they think you don't have their best interests in mind, right? There are a whole host of other factors that come into play that I think, in our busy, productivity, minded, healthcare delivery model, we often either overlook or don't have the time to talk about and really investigate. And it comes down to a lack of understanding, right, of why you've suggested that somebody do something. A cultural or religious or language related conflict. Um, with language, often being linked to lack of understanding, or education being linked to lack of understanding, um, or an inability to pay, right? So, thank you, doctor, for recommending this $200 um, service that I could use to help me lose weight, but I'm living on $600 a month or $800 a month, and I just can't afford that. I have other more elemental basic needs that I have to attend to before I can handle this. Um, so that's a very long-winded way of saying social determinants of health, right? One of the factors that I think we don't do as good a job of managing as we and intervening upon to try to correct as we could, and should. But I think that there are also factors related to understanding, right, related to education, related to cultural upbringing, ethnic upbringing, right, not good or bad, just different.
Mm-hmm.
That we don't do a good enough job of really delving into and trying to address. And these are time consuming. Getting to that second layer, right, of and addressing the skepticism is time consuming and requires a lot of effort and work. And I think anything that requires effort and work and time is something that you unless you're really committed to it and you prioritize it is harder to get done consistently.
Well, and to that point, I mean, there's situations where household finances are really tight, and to pay, in our hypothetical, pay a third of my monthly take home for this service that makes me healthier. I
Yeah,
gotta put gas in my car. I have to feed my family. There's just no way
abs-
that's gonna happen.
yep,
So when you hit that, just that reality that that's just, in this situation, they're not going to do that $200 a month service. What have you seen, or what's the best chance to get adherence to a plan? And obviously,
yeah,
let's keep this big picture. Adherence to the plan is making a patient healthier, not that
yeah,
you, not for
absolutely,
your own
100%.
satisfaction.
That's right. So I think, honestly, it's the easiest thing in what I do in my own clinical practice is to try to understand, right? Because I think when people are resistant, there's often a reason, and you just have to. There's almost always a reason, and you have to understand that. It's not a. I very rarely come across somebody who has said no to something, or I don't want to do this just because, right? And so it's about understanding that reason and coming up with a way to help the person to understand why you're recommending it. And there are times where the trust is an issue, and so you have to try to delve into that trust. Um, I think there are other members of the extended care team who can play a role here, right? So this doesn't have to all on the hands of the physician or the nurse practitioner or the physician's assistant who is seeing the patient for their clinical needs. There are, you can train a medical assistant or a community health worker or a nurse, right, to help probe for and understand how to, and provide guidance around how to address some of these concerns, and some of the barriers. There are services for addressing social determinants of health. Aunt Bertha is one. There are a handful of others like it that provide access to, recommend, lists of social workers, shelters, guidance on how to navigate food insecurity, all sorts of kind of many of the things that we need to get better at trying to address to improve population health.
I think that food insecurity piece is a really tricky one.
Yeah.
You know, not to simplify it too greatly or to come across as out of touch, but if you are able to afford some food and you're in a spot where household finances are tight,
Yep.
you may be hitting the drive-through on the way home, and that's fine. We all do it. Who doesn't love that once in a while?
Yep. Yep.
But getting the patient and getting the population at large to understand, hey, that's an easy choice today, but that's a bad choice for tomorrow and the day
Yep.
after. And then eventually you're going to come see me with an emergency, and you're not going to say I told you so. But do you remember all these things we talked about, that this is preventable only if you make a different choice? That's got to be incredibly difficult.
It is, and it's a as hard as this is to hear, it's a situation by situation intervention, right?
Mhm.
Because and that's why it's, and I don't want to say there's no scalable approach. I think there are ways to scale approaches, but I think fundamentally you have to personalize that set of interventions in order to make it successful. Um, and you have to do so without prejudice or judgment, right?
Of course.
Because and I think, so when I talk about adhere, a lot of people use the term compliance, right? Somebody is non-compliant with X or Y. Um, I almost never use the term compliance. I use the term adherence, because compliance implies volition, right? Adherence is just a statement of yes or no, right? Somebody is either doing something or not doing something. It says nothing about motive or desire to not do something. And so I think removing the the stigma around why people are doing or not doing what we are recommending that they do is very important for starting to get at some of the root causes.
Sure. And this is going to pivot us a little bit once again. In the
Yeah.
time since we last spoke, and certainly these drugs were on the market in January, but things like Ozempic and these injectables that are being hailed as like miracle weight loss solutions, and again through the lens of healthier patients for procedures to be completed
Yep.
immediately at the ASC. Do you have any thoughts on those, or what are you seeing?
Yeah. I mean, so the GLP-1 receptor agonists I mean, are are being used so widely now, and I think we're still early in their uptake. Uptake in my experience has been limited by, frankly, by availability, right? Not by the need. And I think the more we learn about this class of drugs, the more benefits we discover. I mean, there was a really important study which was presented. It was either at the 2020, I think it was at the 2024 American College of Cardiology meetings. looking at reductions in cardiovascular outcomes amongst patients with obesity, without diabetes, without cardiovascular disease, who were treated with this class of medicines. And um, that study showed, it was a landmark trial, showed that treatment with this class of medicines reduced the risk of cardiovascular events, even among people who had no disease and among people who had no diabetes.
Wow.
So, you know, really remarkable outcome. And I think, we are going to see a continued battle between payers and the manufacturers of these classes of medicines, over price and prior auth criteria, because the potential uses of these medicines are just so broad. I mean, I I'm the last time that I was kind of, the last time that I there was this much, concern about uptake of medicines of this type of, about basically such wide use of this class of medicines that we would bankrupt, our healthcare system, was with the PCSK9 inhibitors, which were a class of medicines, that we use to treat high cholesterol.
Mm.
And those came out in kind of the 2015, 2016, 2017 period. And there was a lot of speculation that, at their price point, which at that time was $13,000 to $15,000 a year, and the eligibility criterion, we were just going to see, hundreds of billions of dollars go into buying these medicines, and it was going to bankrupt our healthcare system. That didn't happen, of course, and part of what happened is the cost of those medicines was eventually cut, from that $13,000 to $15,000 range to somewhere in the $5,000 to $7,000 range, and that was in large part due to the fact that payers were putting up such substantial prior auth barriers to use that people weren't getting access to the drug.
Mm.
Um, I haven't seen, these drugs are priced at a lower price point, and I've seen generally broader approvals and uptake. And I think, and they don't have major, I mean, they have some side effects, but people do certainly experience side effects. But the demand for them has just been so dramatic that, I don't. I think they're going to be they're one of the major tools in our clinical arsenal right now for managing obesity, coronary artery disease, even congestive heart failure, and kidney disease.
And I certainly don't have a clinical opinion to offer on anything, as a matter of fact, but it seems like such a breakthrough. And in a slightly cynical way, I can't help but say, what an American way, or what a showcase of the American way. Inject me and I
Yeah,
will get healthier. That's about as good as it gets.
yeah, and yep. I think, yes, I um, I think, it's there. It's really a stunning breakthrough. It will be really helpful for patients. I mean, if you think about just the treatment of obesity, I mean, prior to these medicines, you had lifestyle interventions and then weight loss surgery,
Hmm.
and 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 so, weight loss surgery is still around, still being used. It's still a very important part of the treatment paradigm, but it's certainly obviously more invasive. Requires more recovery time than just using an injection. So, we've already seen some oral formulations of semaglutide come out. That's Ozempic or Wegovy, and then, I suspect we'll see some other oral formulations for some of these other agents over time, and probably some other versions of this class of medicines continue to come out and get tested in clinical trials.
And just I can't help but state, like, what a miracle
Yeah,
for those that need it,
for
truly.
those that need it, it's a huge, yes, absolutely, a miracle, and for 100, absolutely.
And on the other end of this, before we started to record, we even were discussing how exercise is a really important pillar to overall health, though
Yes.
not necessarily a silver bullet. So we're going from one end of the spectrum where an injection and even an oral solution now, it sounds like, can be your ticket to better health. That's good. That's as easy as it gets.
Yeah,
Love
a
that.
pill, not
The
a,
pill.
not a,
Okay.
not a, not an, I don't think not like a solution, but yeah. So sorry, oral formulation. Yes, a pill. Yep. Yep.
Excellent. And then on the other end, if you can, I guess if you can swipe your credit card, you can get these medicines, and that's as easy as it gets. But
Yeah. Yeah, there
what's
are some companies out there that have started to basically, just focus on prescribing, managing, metabolic, cardiometabolic, um, um, conditions, right? Obesity, diabetes, obesity, high cholesterol, high blood pressure. But the at the core, I think, of the treatment approach or the intervention is the ability to prescribe these class of medicines. And I don't know much about those. I've just read about them, heard a little bit about them. These medicines do have side effects, and they need to be titrated, from the starting dose up to their steady state dose. And some people can't get all the way up to that dose because they're limited by side effects. So you really should, you should make sure, a um, just as a point for patients or who are listening, you should make sure that when you start one of these medicines, you're starting it with somebody who you have a longitudinal relationship with, who's going to follow you, who will help manage you through any side effects, right? Not just somebody who's going to write a prescription and then say I'll see you later, like that. I'm not saying those exist, but I think in general, management of prescription medicines should always be done in under the care of a not just a qualified professional, but somebody who can follow you longitudinally.
very very well put. Talk to your doctor that you have a relationship with. If that
Yeah,
wasn't clear, talk to your doctor before embarking on a GLP-1 agonist
that's
journey.
right.
And on the other end of the Ozempic spectrum for better health, we've talked a little bit about food, social determinants of health, exercise, obviously key, back through
Yes.
the lens of CVA USA, cardiology procedures in the ASC, just being a healthier person or a healthier patient and having access to maybe more effective treatment if you take your health into your own hands.
Yeah.
I can't imagine there's a whole lot of news. And if it is, it's old news. Exercise, good for you. But what,
Exercise, great for you, right? Like there's a reason why it is in all of our guidelines as a class 1 recommendation. And that is that we have tremendous evidence that exercise is beneficial. There will always be that one person who says, you know what? I don't exercise. Look at me. I'm 95. I'm doing everything that I want to do, and I'm living a great life. And I'm not saying that person is wrong about what's right for them. But when you look at a population level, um, exercise saves lives. It prolongs life. It's one of the best medicines that we have, and I think a great example of that is cardiac rehabilitation, right? Which is indicated after you've had a heart attack or a stent, or if you have congestive heart failure, or you've had a valve replaced. We do a terrible job in this country generally of helping people to access cardiac rehab, despite having tremendous evidence that if you go through cardiac rehab after one of those events or procedures, your likelihood of returning to the hospital is lower. Your likelihood of dying is lower. Um, and so this is kind of it's an area of intense focus for us at CVA USA, improving access to cardiac rehab and making sure that our patients who need kind of supervised exercise therapy are able to receive that, whether it's through a center or, frankly, increasingly in the comfort of their homes using a home-based cardiac rehab solution.
I'd be curious for your thoughts on this. Obviously, cardiac rehab is one thing.
Yeah.
That's post facto. You have to do this to remain as healthy as possible. But before you
Yep.
get to that point of needing cardiac rehab, to kind of flash back to the socioeconomics of this, not
Yeah.
everybody can either want or afford the Equinox or the Lifetime Gym membership. Not everybody can can or wants to buy a Peloton for their home. However, and this may be a little crass, you already have shoes and you certainly have a place that you can walk somewhere,
Mhm.
somehow, some way. So without putting words in your mouth, what's the recommendation to those that go, man, I'd love that gym membership, but I can't have it. I can't afford it. I don't want
Yeah.
it. What do you tell that patient?
Yep. Two things. I think first, talk to your doctor to make sure it's safe for you to exercise, which for the vast majority of people, the answer will always be yes. But again, I don't want to give a blanket recommendation without, um, because there is that you know that small, tiny percentage of people who probably should really make sure they run everything by their physician first, and then build a short walk into your daily routine, and do it early in the day when you're generally fresh and have the most energy. And Don't set otherworldly expectations for yourself. Just start with 10 minutes or 5 minutes or 15 minutes, whatever you think you can do in a way that's not going to make you hate exercise, and start doing it consistently, and then build up slowly from there.
Wise words. And I know we're coming up to the end of our time today, Dr. Blumenthal. Pivoting hard here once again. We talked about how cardiovascular procedures in the ASC made a bunch of headlines earlier this year, and they're still there, but
Yeah.
the excitement in the press has waned a little. One thing that hasn't waned at all this year, and probably will remain a hot topic for the foreseeable future, is AI, or artificial intelligence in healthcare. What are you
Yeah.
seeing? What are your thoughts? Well,
Yeah.
what's useful to you?
Yeah. So I think we have started to use. I think we've seen some potential value in AI solutions that can automate, back office operational tasks, workflow, streamlining workflows, those kinds of things. Um, when it comes to clinical care delivery, obviously, I think whenever you're touching a patient or um, intervening on a patient, you have to have a higher level of scrutiny than you would just for doing administrative work, and a higher level of evidence, not just of safety but also of efficacy. So I think, for clear reasons, we're not quite as far along there, at least in terms of getting interventions that move the needle in the clinic. But there are a few technologies that I think are really neat, that are making their way through various approval processes. I mean, one is an AI based EKG review tool, which can help just analyze an electrocardiogram, and um, help you understand whether a patient has had atrial fibrillation in the recent past or will likely go into atrial fibrillation.
Hmm.
To me, that's a really neat use case. And then some AI based, or automated, echo reading algorithms that there are a few companies working on that we've seen that I think will help speed up the process of reading echocardiograms and preparing those for the physicians who ultimately will read them.
I love to hear that. And that, you hit the nail on the head that to be able to get these technologies into the hands of providers, but before you do, they need to be back tested. You need huge chunks of data. So, at least in my personal opinion, the really good stuff isn't there yet. There's some good
Right.
stuff out there, but the really good stuff is coming just because for it to be really good, it needs to work
Yep.
most of the
That's
time,
right.
almost all the time.
That's right. And for when we're talking about clinical care, right? We have to have good evidence that it works. Yep. I think we're making. I mean, I've seen really neat, good progress, but it's we've still got a ways to go.
And we were going to get there. And as we wrap up, Dr. Blumenthal, how can listeners connect with you? Any social medias? Are you speaking at any upcoming events? Where can folks get more?
Um, Great question. So you can reach out to me through LinkedIn, or my Twitter, or through X, at Blumenthal DM1, or you can email me dblumenthal at cvausa.com.
Fantastic. And as usual, we'll get all the links to those profiles into the show notes. Dr. Blumenthal, thanks again. This was fantastic.
Oh, had a great time. Thank you so much for having me on, Eric. It was great.
It's our
Always a pleasure.
pleasure.
Yeah.
And on behalf of the entire Doc Buddy team, thank you for listening. Be sure you're subscribed on Apple Podcasts, Spotify, and YouTube, and we will catch you on the next one.